will be the chair of this session, and together with me is Dr. J. Javier, who will be the co-chair. So the objective of this session is to present updates on the status of emerging infectious diseases in the Philippines and to discuss the challenges, possible solutions, and prevention control measures being done for these emerging infectious diseases. And we are very fortunate to have three luminaries in the field of emerging infections for this afternoon. So our first speaker is a medical specialist at the Disease Prevention and Control Bureau of the Department of Health. She is currently the National Program Manager for Emerging and Re-Emerging Infectious Disease Program. She served as the Country Emergency and Project Medical Coordinator for Medicine Sans Frontier, Doctors Without Borders, including projects for HIV/AIDS, tuberculosis and drug-resistant TB, and infectious disease outbreaks. She also served as the Nutrition Cluster Coordinator and Emergency Response Officer of UNICEF. She also served as an Associate Professor at the UP College of Medicine, UPPGH, and as the DOH representative for Doctor to the Barrios for Region 4. So to talk about emerging infectious diseases in the Philippines, ladies and gentlemen, let us all welcome Dr. Gemma M. Arellano.
Good afternoon. Okay, I'm honored to share the program that we have in the Department of Health. It's called the National Emerging Re-Emerging Infectious Disease Program. Start with the first slide. This is a generic slide which I always share when I give a talk about emerging infectious diseases. So it comes from CDC, and it's a fact sheet which presents the outbreaks. It says deadliest pandemic in history. Okay, you will see the slide: smallpox, measles, Black Death, which was the plague, Spanish flu, and all the other diseases that caused pandemics in history. But apparently, it's actually not in history, because these diseases are also now re-emerging or recurrent in other countries and also in the Philippines. Example is the measles outbreak. We have a lot, and also in other countries in the world, there are a lot of measles outbreaks. Smallpox is supposed to be eradicated, but right now there are studies which shows that the cousin of smallpox, which is the monkeypox, which I know you've heard about it, is already present or detected in mostly African countries. Spanish flu has a different variant right now. You have the avian influenza, the Spanish flu. So it just says that my point is, it's actually not in history. They're still with us. The next slide is also a generic slide. I would like you to look at the bottom portion. So it says, the ones in red, this is the map of the world, wherein you have the newly emerging or the new pathogen that causes emerging diseases or outbreaks. And then the blue ones are the re-emerging or the resurging diseases, which I will explain in my subsequent slides. And the black one is the deliberately emerging, or for bioterrorism. Because right now, the warfare is not anymore in armed conflicts or bombs. Actually, countries use biological agents. And which one is the black one? It's the anthrax. Back in 2014, when good people sent the anthrax spores in order to wreak havoc in the United States. This is a slide which shows the magnitude of the emerging infectious diseases in countries in the world. You will see the Europe, North America, they're actually the ones with the most of the newly discovered pathogens, contrary to what people believe that most come from Africa or Asia. It's just that when it's in Africa or Asia, it's highlighted in the media or in the news because a lot of people die because of the broken health system. But as you can see in this slide, most come from Europe and North America. This is an important slide because when we talk about emerging, re-emerging infectious diseases, we don't talk about only the morbidity or mortality that it causes. You have to consider the economic impact that these diseases bring to the countries. You will see in the slide SARS, where I cannot read, I don't have my glasses, and you have the foot and mouth diseases, the H1N1. You will see the magnitude of the circle, the economic impact brought to the countries where the diseases struck. So this is a very important slide for those who are in public health, also in the clinical practice, if you want to be really contributing to the health of the country. Because if you are partners in dealing with these emerging infectious diseases, then it would also help downgrading the impact, the economic impact of the diseases in the different areas in our country. Factors that contribute to the emergence or re-emergence of pandemic infectious diseases. We have to understand how does it bring about, like how come it arose, these emerging, re-emerging infectious diseases. This came from ABCD, or the Asia Pacific Emerging Strategy for Diseases. So it's changes in demographics and behavior, changes in technology and industry, international travel and commerce, microbial adaptation and change, as the previous speaker already spoke about, breakdown of public health measures, and environmental change and land use. All these contributing factors bring about emerging infectious diseases. Because before, I think the idea of emerging infectious diseases came about when the HIV was discovered. So because it really brought a lot of mortality now in our era. So you have to consider all these factors in order to understand why we have now a lot of emerging and re-emerging infectious diseases. Also noteworthy to see the inner circle, or the second layer, increase in host susceptibility, new diseases that are discovered, and increase in disease transmission. So this is just a slide which shows the year that the pathogen was discovered, the different emerging infectious diseases. This is another slide, another set of infectious diseases that's now, before, when it was discovered, it was emerging infectious disease. In the Philippines, we have a timeline. So we start with Ebola Reston. Although it didn't affect humans, still it is considered by the program or Department of Health in collaboration with the Department of Agriculture. Why? Because it has a big economic impact, even though it's just the animals who die, like the horses, the pigs, and the other domesticated animals. You also have the bioterrorism caused by anthrax in 2001. You have the SARS outbreak, 2003, which you also have mortalities when it happened here in Southeast Asia. In 2009, the pandemic H1N1. And then in 2014-15, the Henipa virus outbreak in Sultan Kudarat and Ebola. And 2016, Zika. So recently, we had a new pathogen entering the country. It's the H5N6 avian influenza. So it started, as maybe some of you know, in Region 3. So now it's in the country, and we're monitoring the disease. We don't have humans affected by H5N6. It's just the chickens, the ducks. So this is just a slide to show what is endemic, epidemic, and pandemic. So endemic is within the country or area. The organism is inherent or thriving in the area. Epidemic from external, or it can be within. Okay, don't presuppose that epidemic is from outside. It can also be within the area or within the country. The only premise is that it's beyond the outbreak or epidemic threshold, which we usually compute taking a 5-year trend of the area or the country. Pandemic occurring worldwide, it actually crosses international borders. So that's when you consider the disease to be a pandemic magnitude. So, but in WHO, there are 3 criteria for it to be an pandemic probability magnitude. So number 1, it is a novel human subtype. So it's a newly discovered disease. Number 2, why it can cause pandemic, because we don't know how to treat it. We don't know how to prevent it, because usually we don't know yet the modes of transmission. That's why it has a bigger chance of being transmitted and crossing borders. Number 2, the virus can replicate and cause disease in humans. So it may cause diseases in animals, but when it crosses over to humans and it replicates in the humans, then it also satisfies the criteria to be of pandemic probability or chance. Number 3, efficient person-to-person spread. So in order for it to be pandemic, it should be, it's easy to transmit the organism from person to person or humans, and then it can spread rapidly in the human population. Emerging infections are newly identified, previously unknown infections or diseases. So that's the definition of like SARS and MERS-CoV. It was considered back then as emerging. Re-emerging is secondary to the reappearance of a previously eliminated infection. So it was controlled or eradicated before or eliminated in a country, and then the number of cases increased, or there's at least one. Public health emergencies of international concern is very important. We call it the PHEIC. You will hear it when you study or when you read journals on emerging infectious diseases, the PHEIC, or Public Health Emergency of International Concern. It's based from the WHO International Health Regulations back in 2005. So it constitutes a public health risk through international spread of disease. So for us in the Department of Health, when the WHO declares that it's a PHEIC, then our member states, like us, we have to prepare, and we have to start our preparedness plan and even the response plan. That is our trigger in order to activate our response. So far there are 4. April 2009, the influenza pandemic. May 2014, the wild-type polio virus. 2014 in August, the Ebola virus, which we heard in West Africa. And in February 2016, the Zika outbreak in Brazil. So since 2005, there have been 4 PHEIC. So in the Department of Health, in the program, we only handle for now, as of November 29, because it changes, so these diseases. So we are vigilant in watching these diseases. If ever it did enter the country, then we are monitoring them. The ones in blue, the leptospirosis and meningococcemia, are technically not airy diseases, as you know. This is an ongoing endemic disease, but then it causes, it may cause a severe like magnitude or outbreak like what happened last few months ago. That's why it's included in the ARID program. Yellow fever and wild polio we are monitoring because it has the chance to be a re-emerging disease and it enters the country. So I'm just going to flash a couple of slides just for you to know what the emerging diseases, as I said, that we are monitoring in the Philippines. The SARS outbreak in 2003. So the signs and symptoms, we actually asked the help of the LGU and the private practitioners like you in order to help us battle the emerging infectious diseases. So we would like that, in order to, the idea is not for you to handle the case, because it's really, I will show you there are only 17 hospitals capable all over the country to handle the case, and plus 3 private ones. But please try to study the signs and symptoms, and we would like you to help us detect the diseases if they come to your clinic or the community. So this is SARS, H1N1, the pandemic influenza, avian influenza, Ebola reston virus, the MERS-CoV. We still have a lot of MERS-CoV, and our OFW kababayans, actually we're still monitoring them if they come from Middle East, because there's a lot of cases still of MERS-CoV. The Zika virus. But the Zika virus now is under the Aedes mosquito-borne program because it's already endemic in our country. It's not anymore an emergent or emergency disease. That's why it's in another program. But back then, it was in the ARID program. Ebola virus. So the last, it's actually still current, the Ebola outbreak in Congo. So back then, as of May 27, these are the statistics. And the Henipa virus, the one that happened, the outbreak, if you heard about it, the Henipa outbreak in Kerala, India. Why I want to highlight Henipa? Because it has high fatality rate of 40 to 75%. There's still no prevention, there's still no treatment, and there's still no vaccine. What we know is that it comes from bats, the flying Pteropus species, the flying foxes, they call it. And the Philippines is part of the flight path of these bats. So that's why we're on high alert on the occurrence of the Henipa virus in the Philippines. So I'm just going to scan through a lot of policies that the Department of Health has formulated. We have the Executive Order number 168. It's the creation of the Interagency Task Force. So when there's an epidemic in the country, then this task force signed by the President will be activated. These are the different departments of the government, even the police and the military. If there's a pandemic or epidemic, then they will be activated. The Administrative Order number 10 is the Philippine Interagency Committee on Zoonosis, because 70 to 80% of the emerging infectious disease come from animals. That's why Department of Health, Department of Agriculture, and Department of Environment and Natural Resources, we work together on safeguarding these zoonotic diseases. So this is the vision of the Re-emerging Infectious Disease Program. The mission, our goal, which is prevention control of arid diseases becoming public health problems, and our strategic priorities. So this is our conceptual framework, how we work in the program, and we have a lot of partners because the arid program cannot work alone, so we have a lot of partners in order to tackle the problem. For the operational framework for response, we handle it in pre-event, which is preparedness. We do a lot of preparedness, capacity building, and logistics, and the event for the response, and post-event, documenting everything, and also learning lessons learned. So we have 5 modes of transmission that we monitor because these are the common modes of transmission of arid. So blood and fluids like Ebola, food and waterborne like E. coli 1057, vector-borne like Zika, respiratory droplets like the avian influenza, and zoonotic like anthrax. So it's just a slide which shows this is our response framework. We handle the disease or the threat of the disease using 4 doors. Door number 1 is out of the country. So if there's a Filipino identified to be a suspect of arid, then that we coordinate with the Department of Foreign Affairs. Okay, so we help the kababayan and also not let them enter the country. Door number 2 is at the port, where we partner with the Bureau of Quarantine. That's why you see the yellow form, the health declaration form. That means we're on high alert. So please fill up the form because we need it for tracking if ever there's someone who entered with the disease. Door number 3 is the case is identified from the community or the hospital, and door number 4 is actually the actual epidemic. So these are the hospitals that we, according to the administrative order, that are capable to handle arid diseases in the country. There are 17. These are the laboratories done by our National Reference Laboratory, RITM, for the diseases. And we have 5 sub-national laboratories all over the country because it's hard to send a specimen to RITM. And these are just maps of the area referral hospitals all over the Philippines. The National Reference Laboratory and sub-national laboratories. The BAI, or Bureau of Animal Industry, if it's a zoonotic disease. They also have reference laboratories all over the country. And then meat inspection, if it comes from raw meat that is sold in the market. So my last slide. So now the way forward for the program is actually to handle the zoonotic diseases. So we recently had One Health Summit. So it's a partnership of the Department of Agriculture, Environment and Natural Resources, and Department of Health. Why it's important? Because the One Health paradigm will help us prevent and also mitigate zoonotic diseases. If there are healthy animals, healthy environment, then we will have healthy humans, and then we will have One Health. Thank you very much.
Thank you, Dr. Arellano. So for your questions, please reserve them after the third speaker. So for our next speaker, it is a great honor to introduce her. She is the leader of the diagnostics network, Médecins Sans Frontières International, Geneva, Switzerland. She was the former technical officer of the Research, Ethics, and Knowledge Uptake and a team member of the Research and Development Blueprint of the WHO Geneva. She is a former senior consultant of the Department of Infectious Diseases and head of HIV program at Tan Tock Seng Hospital in Singapore, and she is currently a consulting reviewer of several medical journals worldwide. To talk about Ebola updates, friends, let us all welcome Dr. Arlene Christine P. Chua.
Thank you. Thank you for the introduction. And thank you again for inviting me to this meeting. So I'll give an update on Ebola. Okay, so just jump into it. So Ebola virus, it's a non-segmented single-stranded RNA virus. So it's a member of the family Filoviridae. So the genus Ebola virus is divided into 5 species. So you have Zaire, Sudan, Thai forest, Budimbugyo, and Reston. The 4 species that cause disease in human is Zaire virus. This was first recognized in 1976 and has caused multiple large outbreaks in Central Africa with mortality rates ranging from 55 to 88%. So it was the causative agent in the 2014 to 2016 West African epidemic. The Sudan virus has been associated with a case fatality rate of approximately 50% in 4 epidemics, 2 in Sudan around in the 1970s, 1 in Uganda in 2000, and another in Sudan in 2004. The Thai forest virus, it's only been identified as the cause of illness in 1 person in the Ivory Coast, and that individual survived. Budimbugyo virus emerged in Uganda in 2007, causing an outbreak of Ebola virus disease, but it has a lower case fatality rate, approximately 30%, compared to Zaire and Sudan virus, which are higher fatality rate. Another epidemic of the Budimbugyo had a case fatality rate of 22% among confirmed cases in DRC in 2012. And of course, the 5th Ebola species, the Reston virus, this differs markedly from the others because it is apparently just maintained in the animal reservoir in the Philippines and has not been found in Africa. So for epidemiology, I just chose this kind of selected Ebola outbreaks of more than 100 cases prior to the current outbreak. So I'm not going to go through it, but it does show a varying case fatality. But the one that we have seen the most, like I mentioned, is really the Zaire strain. So this is the current outbreak in DRC. So since 1976, there have been multiple recognized outbreaks of Ebola virus disease in the DRC. In contrast to the 2014-2016 epidemic in West Africa, these outbreaks usually involve fewer than 100 cases and have been contained within a period of weeks to a few months. All but one has been caused by Zaire strain of the virus. So this year, there have been 2 outbreaks that have been reported. So the first outbreak was detected in early May, and there was an intense response from the DRC Ministry of Health, WHO, ALIMA, Médecins Sans Frontières, and other international organizations to rapidly establish Ebola treatment facilities, case finding, and contact tracing to prevent further transmission. The end of the outbreak was actually the first outbreak this year was ended officially in July 24. They had 38 confirmed cases and 16 probable cases. There were 33 deaths. The case fatality was 61%. They also did the ring vaccination with vesicular stomatitis virus, Zaire Ebola virus. They began it less than 2 weeks after the outbreak has started. Nearly 4,000 healthcare workers and contacts of patients and their contacts received the vaccine. So I'll discuss a bit more about this vaccine in the latter part of my presentation. And then again, this year in August, there was another outbreak in DRC. The difference was, this was in the first outbreak, it was in this part. But in the second part, the one in August, it's more in the northeast of DRC. So this outbreak was in North Kivu province in the northeastern region of the country, bordering Rwanda and Uganda. And that particular area, there's long-term conflicts there and a lot of refugees. So it's currently the current outbreak is in a very challenging security situations. There are mobile field labs and Ebola treatment centers, but it just adds another layer of difficulty because of the security issue. It's very difficult to do contact tracing and really find out what's going on. Having said that, the Ebola vaccine has been started, and they've also received experimental treatment products. Again, I will discuss that in detail in my presentation later. So this is the current outbreak. So as of November 11, 2018, they have 333 cases, and the deaths is actually quite high, 209 deaths so far, and they still have cases. Okay, so transmission. So epidemics of Ebola virus disease are generally thought to begin when an individual becomes infected through contact with the tissues or body fluids of an infected animal. Once the patient becomes ill or dies, the virus then spreads to others who come into direct contact with the infected individual's blood, skin, or other body fluids. In terms of risk transmission through different body fluids, the likelihood of infection depends upon the type of body fluid to which an individual is exposed and the amount of virus it contains. So transmission is most likely to occur through direct contact of broken skin or unprotected mucous membranes, which with virus-containing body fluids from a person who has developed signs and symptoms of illness. So the most infectious body fluids are blood, feces, and vomitus. Although infectious viruses have also been detected in urine, semen, saliva, aqueous humor, vaginal fluid, and breast milk. So testing has also been identified viral RNA in tears and sweat, suggesting that infectious virus may be present. The risk of Ebola transmission obviously also depends on the quantity of virus in the fluid. So during the early phase of illness, the amount of virus in the blood may be quite low, but levels then increase rapidly and may exceed 10 to the 8 RNA copies per ml of serum in severely ill and moribund patients. So epidemiologic studies have also shown that family members who are at greatest risk of infection if they had physical contact with sick relatives or their body fluids during the later stages of the illness, where we expect the viral load to be very high, or help to prepare a corpse for burial. For convalescence period, infectious viral or viral RNA can also persist in some body fluids of patients recovering from Ebola virus disease, even after it is no longer detected in the blood. So As examples of follow-up studies among 40 survivors in the outbreak in Kikwit in 1995 in DRC found that there's viral RNA could be detected by PCR in the semen of male patients up to 3 months. An infectious virus was also recovered from semen of one individual 82 days after disease onset. A study of patient samples collected during an outbreak in Uganda in 2000 detected virus in the breast milk of a patient, even after virus was no longer detectable in the bloodstream. And 2 children who were breastfed by the infected mother died of the disease. During the 2014-2016 West African outbreak, infectious virus or viral RNA has been detected from several sites, so urine, semen, aqueous humor, and CSF. And although transmission from persistent virus at these sites is possible, the risk of transmission is not really well established. So as an example, a patient in West Africa who had viral RNA in his semen at least 199 days after symptom transmitted Ebola virus to one, but not to another of his sexual contact. And the transmission occurred approximately 5 months after his blood tested negative for Ebola virus. So, okay. So human infection, as you know, can also occur in contact through wild animals. So I'm not by hunting, butchering, preparing meat, so I'll not go through this in detail. In terms of acquiring Ebola from contaminated surface, there's really no high quality data to confirm transmission through contaminated surfaces, but it's clear that you need to clean the site to remove this risk. Risk of airborne transmission, it's not really transmitted by airborne, but of course, if any procedures that generate aerosols, that could be possible as well. Nosocomial transmission, we know that this happened. Transmission to healthcare workers may occur when appropriate personal protective equipment is not available or is not properly used, especially when healthcare workers care for sick Ebola patients. Okay, pathogenesis. So it's because of the difficulty of performing clinical studies under outbreak conditions, almost all the data on pathogenesis of Ebola have been obtained from laboratory experiments employing mice, guinea pigs, and non-human primates. And case reports and large-scale observational studies of patients in West Africa epidemic have provided additional data on pathogenesis. Observations of disease mechanisms from the epidemic have been consistent with findings in animal studies. So we know that it affects different cells, it disseminates and causes extensive tissue damage. Systemic inflammatory response plays a role in the syndrome, and coagulation defects. This is indirectly induced through the host inflammatory response. I see that the timer 10 minutes. Okay, I will go fast. Clinical symptoms. So the West African outbreak, major hemorrhage is less common. There were a lot of volume losses from vomiting and diarrhea, contributed to the severity of the patients. And we know that it's a spectrum, so we also have patients with milder symptoms. But in general, patients present with early febrile illness, and then after there is predominant gastrointestinal symptoms, a lot of diarrhea, and sometimes quite voluminous, can lose up to 10 liters. And then shock or recovery, and then we'll have late complications. Next. Okay, just skip that. You guys know that. What we also know, a lot of these information also came about from the big West African outbreak. So here, the older age has been associated with the higher fatality rate. Gender, male seems to have a poorer outcome, and perhaps one reason would be a delay in seeking treatment during the last outbreak. Other prognostic factors, somebody who present with more severe diarrhea, they also have a worse prognosis, and somebody presenting with a higher viral load also has a higher mortality. Okay, again, convalescence and late complications. So there may have other clinical manifestations after the acute illness is over. Patients can present with acute arthralgias, hearing loss, skin sloughing, hair loss, uveitis, and meningitis. Okay, in terms of diagnosis of Ebola virus disease, so the purpose of diagnosis is for patient management and epidemic control. So you want to diagnose for early detection, and then to confirm that it is indeed Ebola virus. You want to determine the infectivity, and then post-treatment follow-up. For epidemic control, it's the role of diagnosis is for contact tracing, outbreak detection, surveillance of epidemiological analysis. So you have kind of three kinds. One is rapid point of care. So we now have all integrated nucleic acid test detection that you can test in a decentralized fashion, and you have several lab-based tests, molecular tests. You can test for antigen, virologic assays for case confirmation, clinical management, and of course you have genomic analysis for surveillance and epidemiologic analysis. So, this is really the standard method of diagnosing Ebola virus disease is by nucleic acid testing, RT-PCR. So usually it's detected in the serum within 3 days of symptoms. So if a patient comes before 3 days and if it's negative, but if the signs and symptoms are consistent, you will want to ask that patient to have repeat testing. Immunoassays, the antigen or antibody, this has a lower sensitivity and specificity than NAT testing. And this may cause inappropriate admissions or failure to detect patients. This is, we had, because before the big outbreak in West Africa, most of the diagnosis of Ebola is conducted in a BSL-3 plus laboratory. But then because of the outbreak, there was a need to have a more decentralized testing strategy. So we had asked for a product that could be used in a decentralized healthcare facility where we could easily triage patients coming in with the suspected Ebola symptoms. So indeed, there was, okay, it's a bad slide. So indeed, during that last big outbreak, there were several rapid point-of-care tests that were made available. This just shows its combination of RT-PCR, smaller GenXpert type. You have the BioFire2, as well as lateral flow type tests. This has some regulatory approval. So WHO has the emergency use authorization and listing, and also the US FDA, they have the emergency use authorization for these tests. So GenXpert have developed an Ebola cartridge, so the performance is quite good. It's PCR, as you know. I put here other tests to support clinical management of cases. So you have your ISTAT here and Piccolo and HemoQ for hemoglobin. You would also want to test for malaria because sometimes it's not Ebola, but they also have malaria or they can be co-infected. And of course, you want to test pregnancy. So all of these you can use in a decentralized setting, especially if the outbreak is very big. But the main thing is that there are specific biosafety concerns because for some of these tests, there's a step where you can inactivate the virus and you can work on it safely after viral inactivation. But for some, for biochemistry and all these things, you cannot inactivate the virus. So you have to work on it under a tent like this, biosafety. So this is what the MSF lab kind of looks like. Other labs, this is from Public Health England. It's they set a lab beside the Ebola treatment center. Okay. Clinical management. Okay, so the mainstay of treatment for Ebola virus disease involves supportive care to maintain adequate organ function. And whenever possible, such patients should receive care in designated treatment centers and by clinicians who are trained to care for Ebola patients. And it requires really a multidisciplinary approach to care for these patients. But essentially, the fundamental aspects is preventing intravascular volume depletion, correcting electrolyte abnormalities, and avoiding the complications of shock. So the other thing is investigational treatment. So there are products that are, we know that based on animal studies, that could potentially work for Ebola, but how does it work? So WHO kind of put some framework in terms of how you classify and then decision for the use of these investigational products. So they have this MEURI, which stands for Monitored Emergency Use of Unregistered and Investigational Interventions for Ebola virus disease. It will require special authorization. There should be a protocol before you could use this. It requires ethical clearance from the countries. Patients should have informed consent. And it should not interfere with any clinical trial if there is any clinical trial use of these products. So right now in DRC, the ethics committee of DRC, they are using 5 of these investigational products. I'll go through them one by one. So there are 3 monoclonal antibodies, ZMapp, and monoclonal antibody 114, and 2 antivirals, Remdesivir and Favipiravir. Okay, sorry. Wait, let's start with ZMapp first. So ZMapp, it's a cocktail of 3 monoclonal antibodies targeting the Ebola virus surface glycoprotein. And it was shown in laboratory studies to protect rodents and non-human primates against Ebola virus infection. So it did prevent death in Ebola-infected macaques. So this was the first time treatment has prevented death in primates. And it was evaluated in a randomized controlled trial, 71 patients in Liberia, Sierra Leone, Guinea, and the United States in the last big outbreak in 2016. Although there were fewer deaths in the ZMapp arm, 22 versus 37%, the decline in the epidemic reduced patient enrollment, so we didn't really, it didn't really reach the target number. So there is some evidence available on the data for efficacy of for Ebola therapy, but it did not reach the target enrollment. This is from the PREVAIL-2 study. So it achieved a 91.2% posterior probability that ZMapp plus standard of care was superior to standard of care alone, but this result fell short of 97.5%. Some problems, it needs cold chain, it needs sufficient supply. Because it's an infusion, so it will require a lot of resources to give this to the patient. Next, Favipiravir. This is a nucleoside analog that inhibits the replication of a wide range of RNA virus. So this one, it's actually commercially available, but it's it's marketed as an influenza drug. You use it if it's resistant to other antivirals for influenza. So in vitro, it showed that it could kill Ebola, Marburg, Lassa, but they didn't know what was the dose, so the dosing calculation for Ebola was done through a theoretical model of plasma concentrations. So the advantages is that you can give this orally, it's good supply, it's cheap, more or less you know it's safe because it's been marketed as an influenza drug. But however, it's contraindicated in less than 1 year old or less than 10 kilograms. It's teratogenic, spermatogenic, hepatotoxic. It causes QT prolongation and causes hyperuricemia. There were 2 clinical trials of Favipiravir in the last West African outbreak. The first one is a non-randomized trial performed in several Ebola treatment centers, but again, it was unable to detect a significant reduction in mortality or serum viral load when 99 adults and adolescents were treated with it, compared to people who were not treated in the same center. The other study done at that time, it compared the drug with standard of care over a 10-day period. Statistically significant increase in survival rate seen in the Favipiravir cohort, 56 versus 35% in the controls. But that study has many limitations, indicating that we still need more proof of the benefit of this drug. So for this drug, there is considerable uncertainty as to whether it produces benefit or not to patients based on the currently available data. But of course, being an oral drug, it's more beneficial. It's easier to give in the settings where we work. Although when patients are vomiting, it's oral drug, so it's also the disadvantage. Okay, the third drug is Remdesivir. This is a nucleoside analog that blocks Ebola RNA polymerase and prevents viral replication. So animal data are promising. So this is also currently being used under investigational treatment protocol in DRC. This has less human safety data versus ZMapp or Favipiravir, only anecdotal experience. It was used successfully in at least 1 patient. This was the report. It was given to a baby actually, but that baby also received ZMapp and white blood cell count transfusion from an Ebola survivor. He did survive, but it was a miracle because normally babies born out of Ebola-infected mothers usually die. Okay. Oops, sorry. And then the fifth one is MAB-114. It's a first human phase 1 study started, no results available yet, so they're using this in DRC. In fact, this was the first investigational treatment that they use in the current outbreak in DRC. Animal models looks promising. So this one, this is also a monoclonal antibody cocktail. So if you look at all the products, these are the 5 products that's currently being used. You see that the 2 monoclonal antibodies, 1 infusion, ZMapp, it's a bit more complicated. You infuse day 1, day 4, and day 7. The infusion time is also, for some, it's even the antiviral one, you need to infuse in 30 minutes. Favipiravir already said it's oral drug. You see ZMapp, you have to infuse 6 to 12 hours. It's very difficult. Look at the temperature requirements, minus 20 degrees in ZMapp. In those places, it's very hard to have really cold change. But you see the antiviral, you can just do it in room temperature. And some of the side effects, the hypersensitivity. I'll skip this slide. These are other investigational therapies that were tested in West Africa but didn't go through because lack of evidence. And you know about the convalescent plasma that was trialed during the last outbreak, so that also didn't show any benefits. I'll skip to that. So in summary, therapeutics, the efficacy data for therapeutic agents are lacking. Some of them are inconvenient and maybe not feasible in terms of logistics and human resource to deliver this in the Ebola outbreaks, where Ebola outbreaks occur. Also, this issue of ethical issues in conducting therapeutic clinical trials, especially assignment of patient to control or non-treatment group. Sorry, vaccine. So for vaccine, there are 13 vaccine candidates, including monovalent, bivalent, and multivalent candidates. These are either undergoing or have undergone clinical evaluation and at different trial phases from phase 1 to phase 3, none with regulatory approval. There is only one drug that has been able to provide data on clinical efficacy in the Ebola Sasufi vaccination trial in Guinea. So these are all the Ebola vaccines that's available. I will just speak on 5. So the first is RVSV-ZBOV-C. So this is the only one that has clinical efficacy during a vaccination ring trial in Guinea. It's a live attenuated recombinant vesicular stomatitis virus-based vector expressing the GP gene of Zaire Ebola. The formulation is liquid frozen and 1 dose of 1 ml per dose targeting adults. So the phase 3 trial for this vaccine was undertaken in Guinea. And then in that study, the single dose has shown 100% efficacy with a confidence interval of 64 to 100 in a cluster randomized ring vaccination trial. And it's currently being used in Guinea at this outbreak under compassionate use. So this is what they do. They vaccinate frontline workers, and they also vaccinate, if they've identified the case, they will do contact tracing, and then they will vaccinate the contacts of the patient and also some contacts of the contacts. So as you can see in the current outbreak, in the security issue, it's very difficult to identify this contact to have an effective vaccine campaign. This is, like I said, none of the vaccines are licensed. This is an unregistered product. So still some question, there's uncertainty about the initiation and the length of protection. Storage is minus 60 to minus 80, so you see that the storage thing, it's amazing to transport that, but anyway. It also has some side effects. It can cause some Ebola-like symptoms after you vaccinate, so that may cause confusion in terms of diagnostics. Okay, let's see. Okay, next. Candidate is AD5-EBOV. It's a monovalent vaccine. This is a recombinant adenovirus type 5 vector-based Ebola vaccine using the GP Zaire Makona strain. It's licensed in China under animal rule using data from 8 non-human primates and phase 2 immunogenicity data, but it's licensed for emergency use in case of an outbreak. It has been submitted to WHO for pre-qualification and is currently undergoing review. Another one, this is a prime boost vaccine. So it's a combination of AD26 monovalent replication. This is the prime immunization, and then it's boosted after by MVA-BN phyllo multivalent modified vaccinia Ankara vaccine expressing the GP protein, Sudan virus GP, and Marburg. So this is multivalent. But you have to prime it first, and then you boost with this follow-up vaccine. It has been submitted to the US FDA and requests licensure under animal rule. So this vaccine actually, they had tried to do a phase 3 study in Sierra Leone in the last outbreak, but then the epidemic waned and it was not feasible to conduct the effectiveness evaluation. Next is ChAd3 EBO-Z monovalent. So this is a recombinant replication defective chimpanzee adenovirus type 3 vector engineered to express the GP of the Zaire. It's not licensed and there's no plan for licensure. And then it's similar to the previous vaccine. They tried to conduct some studies in the previous outbreak, but because the epidemic waned, so they couldn't get more information. And then one last thing is the GamEvac-Combi and GamEvac-Lyo. This is a live attenuated recombinant vesicular stomatitis virus VSV and adenovirus serotype expressing the Zaire Ebola virus. This is licensed by the MOH in Russia for emergency use in the territory of Russia, starting December 2015. It's based on phase 1 and 2 clinical data and safety and immunogenicity. There's a phase 3 studies ongoing in Guinea. I just wanted to show this. So there have been some modeling that suggests that the preemptive, if you do a combination of preemptive vaccination of healthcare workers plus reactive ring vaccination, this combination may be the most effective strategy to contain Ebola outbreak. So in summary, progress in vaccine development, there is progress, as you can see, but there are challenges that remain. Some cold chain requirements for some of the vaccine candidates, and the challenges to deploy this in the affected region. The side effect profiles, such as vaccine-induced fever, can mimic symptoms of early Ebola virus and can complicate evaluation of vaccines and create diagnostic challenges. It's unclear also the time of onset of effective immunity, the duration of protection, and cross-protection with the other Ebola species. We need more field efficacy data to also see, they would need this also for full licensure and regulatory approval of vaccines. And of course, the issue about acceptability of vaccine in the affected communities. So thank you very much. And thank you to Anik for sharing some of her slides with me. Sorry, I was late.
Thank you very much, Dr. Chua. So for our last speaker for this session, he is a member, a diplomate and fellow member of our society, the PSMIT. He's a medical specialist at the Research Institute for Tropical Medicine, a member of the AIDS Research Group at the same institution, and a member of Treat Asia, Therapeutic Research Education and AIDS Training in Asia, to talk about influenza H5N1 and H5N6. Colleagues and dear guests, let us all welcome Dr. Mark Christopher Pasayan.
Good afternoon, everyone. And thank you, Dr. Delgado, for that introduction. I was tasked by PSMID to talk to you about the two bird flu viruses, the influenza H5N1 and the H5N6. I have nothing to disclose in relation to this presentation. Now, sorry about the slide, but if you could lean your head to the right, and just one way also to exercise your head and perk you up if you're sleepy. We're actually celebrating, I don't know if that's the right term, we're actually commemorating the centenary of the 1918 Spanish flu epidemic that actually, according to Dr. Arellano's slide, killed around 50 to 100 million people in 1918. And it's just up talaga that we should talk about the influenza A, since if some of you were born at that time, maybe you could tell us your experiences during the Spanish flu. And actually, it was that big that it actually dropped the life expectancy of a lot of people in the world. In the US, it dropped by 12 years. And if you can see in this graph, on the upper graph, there was increase in mortality in the young adult population, and it caused a drop of the life expectancy in the US in the 1918 to 1919. Now, if we talk about influenza, we should always talk about the ABCDs of influenza. Now, influenza influenza virus is grouped into A, B, C, and D, and they're all under the genera of the Orthomyxoviridae. Influenza A affects humans, birds, swines, seagulls, seals, and even killer whales, while influenza B, they cause seasonal epidemics in humans. Influenza C causes infections in humans and swines, and influenza D, it only causes infections among cattle and not humans. Now, influenza A would have the potential to cause epidemic or pandemic because of the ability to infect people and have a sustained human-to-human transmission. And influenza A are classified into subtypes according to the combinations of different virus surface proteins, hemagglutinin and neuraminidase. And there are 18 different hemagglutinins and 11 different neuraminidase subtypes. The reason why influenza pandemics occurs because there are animal reservoirs from which novel influenza viruses are introduced to humans. On this pictograph, there are 18 subtypes among influenza A viruses, and 16 of them are found in waterfowls, shorebirds and gulls. When we say shorebirds, these are the seagulls, or in the Philippines, we don't have seagulls, we have tagak, or the egrets. And 2 were recently identified, and they were identified in bats. And only H1, H2, and H3 have caused influenza infections in humans, and other subtypes have been isolated in other species, like the swines, the horses, the seals, dogs, and even the killer whales. And from H1 to H16, these were isolated from waterfowls. Now let's go to the neuraminidase subtypes. The NA come in different subtypes, with the 2 most recently identified subtypes, the N10 and N11, identified in bats, and N1 to N9 are identified with waterfowls and shorebirds, and only N1 and N2 containing viruses cause sustained outbreaks in humans. Depending on the origin host, the influenza A viruses can be classified as avian influenza. For example, swine influenza would usually have, or some example of a swine influenza is the H5N1 and H9N2, and for the that's the avian influenza, and for the swine influenza is the H1N1 and the H3N2. The primary natural host of the avian influenza are the waterfowls, the shorebirds, the seagulls, and the tagaks, and the wild ducks. Now, the gastrointestinal tract is where these waterfowls would transmit the viruses, and there's always or sometimes a spillover of the virus to other species, like the birds, mammals, and eventually humans. The influenza virus genome has properties that would allow the extent of antigen exchange. The genome is an RNA genome that is divided into 8 distinct segments, and each segment would code for a particular protein. And the 2 major glycoproteins are the two things that I mentioned a while ago, the hemagglutinin and the hemagglutinin and the neuraminidase. Other proteins like the PA, the PB1 and the PB2 would code for amino acid differences that are critical for the adaptation of the virus to humans. Now, these segments, these segments of the genome are important because when a cell is infected by 2 different influenza viruses, for example, an avian virus and a human virus, each of the gene segment is replicated and assembled into an infectious virion that contains gene segments derived from either parent. And this phenomenon is called the genetic reassortment. And in 1957 and the 1968 pandemic influenza, this is what happened. An avian virus had a genetic reassortment with the human virus, causing the pandemic H2N2 influenza virus, and the same happened in 1968 when the H3N2 influenza virus came about because of the genetic reassortment of an H3 avian virus and an H2N2 human virus. Now, pandemic influenza may originate through at least two mechanisms. One is reassortment between an animal influenza virus and a human influenza virus that yields a new virus. This is what we call the genetic drift, or a direct spread and adaptation of a virus from animals to humans, and this is what we call the antigenic shift. This is an example of, or this slide summarizes the pandemics in the last 100 years and showed how antigenic drift and antigenic shift play crucial roles in the evolution of such pandemics. There were 4 pandemics in the last 100 years: the H1N1, the Spanish flu, H2N2, the H3N2, and the most recent one, the H1N1. In the 1957 and the 1968 pandemic viruses, they were derived by genetic reassortment between previously circulating human influenza viruses and animal influenza viruses, while the 2009 and the 1918 viruses were derived from the circulating viruses in pigs, but these are a lot of, there were a lot of genetic reassortment going on in nature in the swine population. But still, we should always remember that the influenza A reservoir are the waterfowls and the shorebirds. Now, there are features of, these are the features of pandemic influenza virus. These are the 3 characteristics to say that an influenza virus would have a pandemic potential. One is the isolation from humans of a novel subtype of influenza to which the general population has little or no immunity. Demonstration of an ability of the virus to replicate and cause diseases in humans, and an efficient spread from person to person expressed as sustained chains of transmission causing community-wide outbreaks. Now, what is the role now of that glycoprotein hemagglutinin in the ability of the virus to infect animals and even humans? Because hemagglutinin plays a crucial role in host range entropism. It is the attachment protein of the virus, and it specifically binds to the sialic acids on the host cell receptors. Now, human influenza A viruses preferentially binds to an alpha-2,6-linked sialic acid, while avian influenza A viruses preferentially binds to an alpha-2,3-linked sialic acid. What is important to note here is that alpha-2,6-linked sialic acids are present throughout the respiratory tract of humans, while alpha-2,3-linked sialic acids are present distal to the respiratory bronchioles in humans, meaning both sialic acids are present in humans. That's why these viruses, which infect birds, can actually infect humans, because we contain the receptors where these viruses would bind. Now, alpha-2,3-linked sialic acids are present in the GI tract of birds. That's why among wild fowls, the transmission is actually oral fecal, and the symptoms usually of birds is gastrointestinal rather than respiratory. Wala naman kayo nakitang ibon na sinisipon or inuubo, di ba? Now, the role of hemagglutinin in host range tropism also points out that influenza viruses would need to acquire mutations in the hemagglutinin to confer an efficient binding of alpha-2,6-linked sialic acids to enable efficient transmission among humans. And the lack of alpha-2,3-linked sialic acids on epithelial cells on the upper respiratory tract of mammals may explain why highly pathogenic avian H5N1 influenza viruses do not transmit efficiently among mammals, because it's way deep in our respiratory tract. Now, this is a long list of the different avian influenza viruses that had direct infections to humans from 1959 to the most recent. And The LPAI are the low pathogenic avian influenza, and they cause mild respiratory or GI infection, while the HPAI are the highly pathogenic avian influenza, which can cause systemic multi-organ infections, as well as high morbidity and mortality. And what's more important to note here are the most recent outbreaks involving a lot of countries in 2003 to 2017, the H5N1 HPAI, and H7N9 in China, although H7N9 is a low pathogenic avian influenza. Another thing that we are monitoring, like what Dr. Arellano said, is the H5N6 HPAI, which originated in China and actually reached our country just last year. Let's go first with H5N1. H5N1 is a reassortment. It's a product of the reassortment between H5N1 and, H9N2 and H6N1. And the virus originated in China. So this is one good example of the antigenic drift, wherein three different genes of three different viruses underwent reassortment to come up with a new virus, the H5N1, and the antigenic shift of crossing the species barrier, those viruses initially infecting birds, eventually infected humans. And the first cases reported in Hong Kong were these 18 Chinese men with 6 reported deaths. This is the timeline published in 2006, and that 18 cases reported in Hong Kong is depicted in this red dot, and this is in 1998. This was the initial cases in Hong Kong, and then a resurgence was noted or was reported in 2003. The green bar are the domestic poultry, and the wild birds would be noted in the blue bar, and the red dots are the human cases. And in this pictograph, you also know that it only, or the H5N1 did not only stay in mainland China, it actually spread throughout Southeast Asia, involving Indonesia, Vietnam, and Thailand, and eventually it reached even Europe and Africa. It all started in this region of China, and a certain clade is involved in the spread of H5N1 in Southeast Asia, and a different clade is involved in the spread throughout Europe and North Africa. Now, what's the reason why there was a spread? It's because of the migratory bird movement contributing to the spread of, or the expansion of the highly pathogenic avian influenza H5N1 in Southeast Asia and East Asia. Now, in 2005, April 2005, there was a large-scale avian outbreak in this area of China, the Qinghai Lake. I don't know if I pronounce it right. Maybe I should ask Dr. Patrick Ko. It's Qinghai. This is a lake in China where there are a lot of migratory birds flocking, and this actually became the source of the spread of the virus to Europe and North Africa. And the geographic spread of the Qinghai lineage H5N1 from China to Siberia, India, Europe, and Africa was largely correlated in time and space with the annual bird migration movement. This is the recent WHO report from 2003 to the recent year, 2018, and this is the cases and the number of deaths associated with H5N1. We don't have any reported cases in 2018, no deaths as well. The last reports were from 2017, and from 2003 to present, there have been 860 cases of H5N1 globally, with 454 deaths out of those cases. So there's a high case fatality rate associated with H5N1. And if you will see in that list, the Philippines is not included because we don't have any documented or reported case of H5N1 yet in our country. And according to WHO, the latest case was reported in September 27, 2017. Now let's go to H5N6. It is a novel avian influenza which emerged in Changsha City, China. It's in the Yunnan province in this part of China. It was discovered in 2014 in wild birds and reported in humans in May 2014. And it's a new emerging infection in humans, and it's because of a cross-species infection. Now, unlike H5N1, I think mas complicated ang genetic reassortment with H5N6 because there's a lot of genes involved from different avian influenza subtypes. There were cases reported wherein the PB2 gene of some H5N6 AIV was derived from an H5N6, whilst the PB1 gene was derived from an H3 subtype. Another case report in China wherein a novel H5N6 was isolated from a migratory waterfowl possessed an HA related to H5N2. In 2014 and 2015, an H5N6 case was noted to be a triple reassortment of H6N6, H5N1, and H5N6. And you can actually appreciate those, or not appreciate those, reassortment from this pictograph. There are 18 hemagglutinins and 9 neuraminidase. So imagine the different combinations that you can get out of those numbers. So actually, when I was reviewing the slide, doon ko lang na-realize yung value ng algebra when we were in high school, the permutation. And until now, I cannot really still understand how to do the permutation. But how many combinations can you get out of those different hemagglutinins and neuraminidases? Anyway, since 2014, and as of August 11 of this year, there were 19 human cases of avian influenza A H5N6 reported globally, and everything occurred in mainland China. And the last case report, reported case in humans was on January 5, 2018 of this year. Which brings us back to the Philippines. Do we have H5N6 in the Philippines? Yes, we do have H5N6 in the Philippines, and it happened last year in Central Luzon in Region 3. H5N6 is close to my heart because I am one of those fortunate or unfortunate ones to be sent by my institution to Region 3 to investigate on that bird flu in Pampanga and Tarlac. And we didn't look at the birds and check whether they have sipon or not, but we went to the 3 DOH retained hospitals and assess their capability to accommodate the H5N6 PUIs. Anyway, so it was a big news back then, and this is one of those photos that went viral because you'll see all those healthcare workers or investigators donned in their PPEs killing all those chicken, and then comes this farmer wearing shorts and carrying a dead chicken on. So that was a big news back then, and even the Secretary of Health and our own medical director, Coco Lopisan, went on TV and gave a brief press conference, and where they ate those eggs to prove that it's not transmissible to humans. Anyway, Secretary Piñol of the Department of Agriculture announced that in September 2017 that the H5N6 outbreak among chickens is over, and thus far I'm not sure if there are still H5N6 in chickens in Central Luzon, but from the RATM surveillance unit, there are no influenza A H5N6 isolated yet in humans. Okay, this is the WHO Global Influenza Surveillance and Response System. This is the oldest network in the WHO. It just shows that we have 144 national influenza centers in 114 countries, and one influenza center is in the Philippines. It is in RITM. And there are 5 reference and research centers globally. One is in Atlanta, one is in London, Beijing, Tokyo, and Melbourne. So if we have problems doing subtypes for the influenza, we actually send it abroad. RITM sends it abroad for the subtyping. And the H5N6 outbreak last year, it was actually sent to Melbourne for the identification. Now, how do we diagnose H5N1 or H5N6 or whatever subtypes of influenza A viruses? The best would still be the real-time PCR performed on nasopharyngeal specimen. It has the best diagnostic value, although serology is available. What is available in RITM is both serology and RT-PCR. I just got a word from the Special Pathogens Laboratory, and they confirmed that yes, we do subtyping, but if there's a need to further investigate on the subtypes of the influenza A, influenza A subtypes, we send it to Melbourne Reference Center. Now, all H5N1 viruses that have been tested are sensitive to your neuraminidase inhibitors. That's a treatment. We have the zanamivir and the oseltamivir. Tamiflu is available in the country. It's available in DOH also for free. These drugs may be effective when used prophylactically, but the window for effective treatment is only limited to 1 to 2 days after initial infection. And neuraminidase activity affects the release of the virion from the host cell. So it affects also the replication of the virions, thereby causing its destruction. Now, can the source of novel influenza A virus be eliminated? Remember, the natural reservoir are waterfowls and birds. In Japan, Korea, and China, they kill birds. They do culling, they do quarantine, and it has an effect on the number of cases. They saw a decrease in the cases, but what's more effective is actually the use of vaccine. Vietnam is using now a inactivated oil emulsion H5N1 vaccine, and it's being used in poultry. It's not being used in humans yet. But remember, we cannot vaccinate all the birds. We cannot vaccinate all the ducks that are flying across the across country. So it might have a role in poultries, in livestock industry, but we cannot know how it will affect, or it can be effective against the wild birds. Now let's go to vaccines. What are the challenges on the universal influenza vaccine development? There's no vaccines yet for H5N6 and H5N1. What we are receiving every year, the influenza vaccines we are receiving every year, are not effective against these avian flu viruses, because what we're receiving from the flu vaccines are H1N1, H3N2, and the influenza B. 1 or 2 subtypes of influenza B, depending on what kind of vaccine you're receiving. So what would be the technical challenges in developing vaccines for this novel HPAI? One is to identify the targets that are conserved across a wide range of influenza viruses, and there's a lot. And also develop a vaccine strategy to induce an immune response that is sufficiently robust to confer protection, elicit at the right appropriate site, given the right time, right dose, and the right site, and given without adverse effects. Now, the regulatory challenges would be immune correlations of protection and assay to measure the immunogenicity. Now, another problem is in implementation. Who should we vaccinate? When do we vaccinate? And how often do we vaccinate? Okay. So this is my last slide, actually. The virus, the influenza virus, is always changing, and mutations that make it more compatible with human transmission may occur at any time. Clearly, we must be prepared for the possibility of an influenza pandemic. If H5N1 and H5N6 influenza achieve pandemic status in humans, and we have no way to know whether it will, the results could be catastrophic. Now, for my last slide, I would like to dedicate this lecture to my mentor, who taught me first that there were 16 hemagglutinins and 9 neuraminidase. And Dr. Chua, I'd like to inform you that there are now 18 hemagglutinins and 11 neuraminidase. Thank you po, and magandang hapon.